Good morning, everyone. Good morning, everyone. Today we'll be talking about the topic thumb sucking habit. Now, we know there are so many kinds of habits in which the oral habits may be a part of the normal development, a symptom of a deep-rooted psychological disorder, or it may be as a result of an abnormal growth as well. Now, thumb sucking, as we all know, is most commonly seen in children. It is concerned to specialists like psychiatrists, pediatricians, pediatric dentists, orthodontists, speech therapists, as well as plastic surgeons. How do you define thumb sucking habit? It is defined as a placement of thumb at varying depths into the mouth. Digit sucking is defined as a placement of the thumb or one or more fingers at varying depths into the mouth. So now when we ask whether is it a normal procedure or is it a normal habit to keep the thumb into your mouth? Yes, till the age of 3.5 to 4 years, we consider it as a normal behavior. But beyond the age of 4, this will cause malocclusions. So how do we classify thumb sucking habits? The first classification we have was in the year 1973 by Subton Lee, who classified it into 4 types, type A, B, C, and D. According to type A, 50% of the children whose digit is placed in the mouth, they press it against the palate, the anterior tooth, and it is in contact. Now we have the type B, which seems about 13 to 24%. This doesn't touch the palate. Then you have the third one, or the type C, that is 18%, in which the thumb is inside the mouth only till the first joint, and then the palate and only maxillary incisors. Type D is very little portion of the thumb being positioned into the palatal aspect. What are the theories or what are the etiology of thumb sucking habit? We have certain theories: the classic Freudian theory, the learning theory, the Benjamin's theory, oral drive theory, and the Johnson and Larson theory. These are the various theories that explains the thumb sucking habit. Coming to the first one, the classic Freudian theory or the Sigmund Freud's theory. He proposed this, saying that the child goes through various distinct phases of psychological development in the early stages of life. For example, in the oral phase, the mouth is the erogenous zone. So during this phase, the child takes anything and everything that comes to the oral cavity, and it is believed that any kind of deprivation of this activity will cause the child to be an emotionally secure individual. Next, we have the oral drive theory, which is given by Sears and Weiss in the year 1982. As per the oral drive theory, the strength of the oral drive is in part of the function of how long a child continues to feed by sucking. It is not the frustration of weaning that produces a child to thumb suck, but in fact, it is the prolonged nursing that causes it. Again, the third theory, we have the rooting reflex theory, which was given by Benjamin in the year 1962. According to this, the movements of the infant's head and the tongue towards an object touching its cheek is the rooting reflex. So the thumb sucking arises from this rooting and placing reflexes common to all mammalian infants during the first 3 months of life. Again, the fourth theory, which states the sucking reflex theory. This reflex occurs in the oral stage of development and is seen even at 29 weeks of intrauterine life, and it may disappear during the normal ages between the ages of 1 to 3.5 years. It is first coordinated muscular activity of the infant, and babies who restricted from sucking due to disease or any other factors becomes restless and irritable. This deprivation may motivate the infant to suck the thumb, and this gradually becomes a thumb sucking habit. Again, we have the learning theory, which was given by Davidson in the year 1967, which states that the infant associates sucking with feelings like pleasure and hunger, and he recalls these events by sucking the suitable objects available, which is mainly the thumb or the finger. So what are the causative factors that we see that enhances thumb sucking habit? The factors that we have come across is the parent's occupation, and the socioeconomic status. Working mothers, they impart an insecure feeling for the children. Then again, the number of siblings. When the number of siblings increases, there is divided attention going to the kids. So either the youngest of the kid is given less attention and he or she develops the habit. Birth order, feeding practices like abrupt weaning. When the child is fed with solid food early at an earlier age, he or she may develop the habit of thumb sucking habit. Age of the child, infancy, feeding problems, hunger, again, eruption pattern of the primary teeth. So how do we diagnose thumb sucking habit? The first and foremost thing is the history taking. We need to know how often, the frequency, the intensity, and the duration of the habit of the child, the feeding patterns, the parental care of the child, and the presence of any other habits that may influence the thumb sucking habit. What are the clinical features, both extraorally and intraorally? Now, coming to the extraoral examination part, if you check or if you examine the digits of the child, you may notice he or she has a clean dishpan thumb, that is a red and clean chapped and a short fingernail, which has fibrous roughened callus on his fingers. The picture here, you may see, you can appreciate it towards his thumb region. You see there's a roughened area here. Again, the lips, if you notice, the child most often has a short hypotonic upper lip or a hyperactive lower lip. When I say a hyperactive lower lip, you can see the chin portion of it. You can see certain indentations or depressions. We call this as a puckering of the chin, or it is also called as a golf ball appearance, that is clinically visible to the dentist. Other features of this include mouth breathing, tongue thrusting, and large tonsils. Now, here in this picture, if you see, there is a constricted maxillary arch. You can see the V-shaped arch, which is away from the normally shaped U-shaped arch. Maxillary arch is U-shaped and the mandibular arch is more or less V-shaped. When a child becomes a thumb sucker, the clinical picture that we see is a V-shaped arch. Now, how many of you know that why do we have the V-shaped arch? The V-shaped arch happens due to the fact that there is a change in the tongue position. When the tongue is being positioned low and when the child is a thumb sucker, there is an excessive force that is being pressured from either sides of the cheeks. That is, there is an inward pressure being pushed. So there is no counteracting forces to stabilize the U shape of the arch from inside. So as a result of this, what happens? The bone constricts. When the bone constricts, the U shape changes into a V shape, and accordingly, the teeth too moves along with the bone. Now here, you see in this picture, there is an anterior open bite. As the picture says, the patient's anterior open bite is a direct result of an active thumb sucking habit. An open bite results when the thumb impedes the eruption of the anterior teeth, moves them facially, and allows the posterior teeth to erupt passively. So what is the effect on maxilla and mandible? What exactly happens? It increases the proclination of the maxillary anteriors. You see there's a midline diastema. There is an increased maxillary arch length. There is increased anterior placement of the apical base of the maxilla. The SNA angle is increased. Increased clinical crown length of maxillary incisors, decreased palatal arch width, and so on. Again, all these features is attributed to thumb sucking habit. You see there is an increased overjet, there is a decreased overbite. As I said before, when the maxillary arch constricts, there is a posterior crossbite resultant. There is increased lip incompetence. When I say increased lip competence, I mean to say that there is no contact between the upper and the lower lip, because of which the anterior open bite becomes more pronounced. Thank you.